Hello and welcome. My name is Raj Persaud and I'm a psychiatrist based in London. Today I'm talking to Professor Anthony David, who's a professor of cognitive neuropsychiatry based at the Institute of Psychiatry, which is attached to King's College in London. And we're discussing a paper that he's written with a team of co-authors. The lead author is Zelaya Aybek, who's a Swiss neurologist who's visiting Professor Tony David in his department in London. And the title of this paper is Neural Correlates of Recall of Life Events in Conversion Disorder. And it's just recently been published in JAMA Psychiatry, or the Journal of American Medical Association Psychiatry. Now, as I said before, the title of the paper is Neural Correlates of Recall of Life Events in Conversion Disorder. And the co-authors are Zelaya Aybek, Timothy Nicholson, Fernando Zelaya, Owen O'Daly, Tom Craig, and Richard Kanaan. So, Professor David, let me start by asking you, conversion disorder, otherwise known as hysteria, is often thought as a kind of ancient or old disorder which people don't see anymore. Is that right?
No, that's a common misconception. It's actually a rather common condition, especially in neurology outpatient clinics, where it accounts for perhaps 16% of all the patients that neurologists see. So what it amounts to is a condition where the person appears to have a neurological disorder, but in fact all the tests and all the examinations show that there is no neurological problem. The inference being it must be in some way psychological. But that, of course, is where the interest begins, to show what is meant by psychological and how the psychological and the physical interact.
And historically, this disorder has been extremely important in the history of psychiatry because a lot of Freud's initial theories seem to arise out of this condition. And he had a theory as to what was going on in this condition.
Well, that's right. So Freud was working as a sort of general practice neurologist, and he kept seeing these cases coming to his clinic of people with apparent neurological disorders that even by the standards of the time he could be quite sure did not have a neurological condition. And he became very interested in what might be going on psychologically. And of course he and Breuer, who wrote their studies on hysteria at the end of the last century, found that patients often reported a traumatic event, often dating back to their childhood. And of course that was very controversial then, and it remains controversial now, especially when some of these traumatic events were of a sexual kind. And Freud and Breuer suggested that the memory of those traumatic events was somehow repressed. But that wasn't the end of the matter. Trying to repress these memories only partially solved the problem, and the difficulty and the stress, it was thought, emerged in the form of a physical symptom, and that was the conversion disorder. So the psychological stress was, as it were, converted into a physical symptom. And Freud and Breuer believed that the kind of symptom had some symbolic importance. So the inability to speak was somehow symbolically important. It was perhaps an inability to speak the truth. Although he also recognized that there was a secondary gain alongside this primary gain, that somehow having an illness did bring some benefits, some relief, some respite to the patient's predicament. And in many ways, those ideas still permeate the thinking today, even though no one's ever been able to really confirm or refute them.
And what's very exciting about your study is it's an attempt to examine this theory using the very latest brain scanning technology. So in terms of the history of research on hysteria or conversion disorder, is this the first time people have tried to prove or disprove a Freudian theory on hysteria or conversion disorder?
No, there have been over the last decade or more a few attempts to have a look at this, and people have usually taken a slightly different tack. So, for example, if someone has an apparent paralysis of a limb where there's no neurological abnormality that can explain the paralysis, what researchers have done is get volunteers to pretend that their limb is paralyzed, or sometimes they've used hypnosis to induce a hypnotized paralyzed state, and then they've asked the individuals, try and move your arm or your leg compared to the good side, and they found that there are patterns of brain activation that relate to trying to move a limb and not being successful. For example, the sort of planning components and the initiation components that begins a voluntary movement, and that they've suggested that these are abnormal in the patients with conversion disorder, and they've suggested that it's not simply pretending not to be able to use a limb. At some level, the patient is trying to use a limb, but the higher motor initiation centers aren't really working properly. And so that kind of research is still very active, and people are pursuing that. Our approach was slightly different. Our approach was to go back in some ways to the Freudian ideas that whatever the conversion disorder was, it was triggered, or at least partly due to some kind of stressful event. And indeed, Tim Nicholson's research showed that when you interview patients, current patients with conversion disorders in a very detailed and systematic way, you do find that their lives are punctuated by a number of very difficult, stressful events, more so than the average member of the population. And he found that in the weeks and months and even days prior to the onset of the conversion disorder, the paralysis or whatever it may be, there were a particular cluster of these very difficult life events, life experiences. So there did seem to be a temporal relationship between stressful events and the beginning of the conversion disorder. So what we were trying to do was try and make the link between how do you get from that difficult stress to a physical symptom. And that's what we were trying to do with our imaging study. So what we did was we got the patients to tell us their stories, and of course we noted some very difficult life events that they had experienced, and we, as it were, recreated some of the memories of these events in a very controlled way while the person was lying in the scanner. So with their full cooperation and consent, of course, we showed them sentences which either did or didn't relate to some of these events that they'd experienced earlier, 2 years ago, on average, at the time that they developed the illness. So we were wanting to see how did their brains, as it were, react to remembering, to reimagining the events that might have preceded their condition. And we found that there were some very interesting differences between healthy people, who of course also experienced difficult life events. When they're reminded of them, their brains act in a different way to the people with the conversion disorder. And the results of the study gave us some clues how the emotion was metaphorically converted into a physical symptom.
Could you say something about what the results lead you to believe about what's going on in the mind and brain in terms of the translation between a stressful event and a physical symptom?
I'll try. So, for one thing, so there were differences in the pattern of the brain activation. So for one thing, events that seemed to be a particular kind of severe event that we called escape events. So if you can imagine bad things can happen to people, but in some of those events, if you're to become ill or disabled in some way, it could have an effect that's in some way beneficial to you. Now, that's not to say that the individual is deviously planning this. We still don't know whether this happens unconsciously or consciously. But, for example, if your spouse suddenly has a heart attack, that's obviously a terrible event to happen to you. But if you then become ill as well, that's not going to help in any way. It's not going to make life any less stressful for you. But if, for example, your partner and you have a row and they threaten to leave, and at that point you develop some frightening symptom, and then perhaps the partner thinks twice about whether they should leave at that point and starts to feel worried and guilty, then in some way you've mitigated the problem. The person stays. Now, again, as I say, I'm not saying that this is a devious plan on the part of the individual, but sometimes that's what happens. And so we say that's an escape event. You've escaped from the worst of the trauma by developing the illness, or at least it might have happened like that. So when people are remembering events of that kind, these escape events, the pattern of brain activation in the conversion patients was very different from the pattern seen in the healthy controls. So, for example, although we would imagine the memory system and the emotion system to be activated, we find that in some ways, so there are additional areas being activated in the conversion disorder patients, areas of the brain that really have nothing to do with memory and emotion, areas to do with motor planning, an area called the supplementary motor area. And these are the sort of areas that came up in the other kinds of experiments I mentioned, when people are trying to move a paralyzed limb or pretending to initiate a movement in a paralyzed limb. So that area lights up. So it's as though immediately something that's very emotional from the past is either causing perturbation in the motor system, or the motor system is trying to deal with this emotional memory. And another area that was activated abnormally in the conversion patients is the temporoparietal junction. And that's a region where sensory inputs from different modalities sort of come together, and it's thought that a sort of coherent sense of a bodily self is something to do with coordinated activation in the temporoparietal junction. Lesions to that area or disruptions to that area disrupt this sense of self. And so again, that seems to ring a lot of bells in conversion disorder, where a person seems to be cut off from the limb that isn't working. So the individual feels that they can't use the limb, they can't raise their arm, they're trying to, but they can't. They are, in some metaphorical sense, cut off from that limb. So those areas activated a lot in this patient group. And we found that when we looked at what the supplementary motor area was strongly connected to, we found indeed that the amygdala, which is part of the emotional brain, the limbic system, showed a very strong connectivity with the supplementary motor area. That those two areas seem to be working in consort. And again, one wouldn't normally expect that. One would expect that these are very different systems, but somehow they're pathologically linked in these conversion disorder patients. So I think we're beginning to see how this conversion metaphor that Freud talked about might actually be part of the mechanism that's occurring in people who develop conversion disorder.
I'm wondering as well whether there was a finding around a difference in memory, the way memory for trauma worked between the patients and the controls.
Okay, well, this is an interesting element. So the original Freudian idea was that the traumatic event had been repressed, in effect forgotten. And it was only through the free association process of psychoanalysis that uncovered the memory, so that the person themselves hadn't been aware of any connection between the event and their later illness. Now, we don't really see that very much, and although some people still think that memories can be repressed in that way, that's highly controversial. But what modern psychology has found is that you can suppress memories in the sense of making them a little bit less memorable by simply not thinking about them. And you can do experiments in healthy people where you ask them, try and remember this list of words, but try not to remember that list of words. And then when you later show those individuals the lists of words that they were not supposed to remember, what you find is that the hippocampus, the part of the brain where memories are encoded and perhaps stored, is less active, whereas the inferior frontal cortex is more active. So that's been interpreted that the part of the frontal lobe is suppressing the memory activity in the hippocampus. Not so much that the person denies ever seeing the material, but it's somehow just slightly out of reach. It's slightly less accessible. And what we found in these patients was indeed, although we had these areas that seemed to be abnormally increased in their activation, the hippocampus was underactivated in the patients compared to the controls when they're being cued to remember these cued events, these stressful events. So it's not that they didn't remember them, but they didn't quite have the same recollective power. And how that translates in what the patients say to us is that often they'll recall the event, but it won't have the same affect attached to it. It won't seem to be so important. So they would say, yes, well, I did have an argument with my partner, and yes, come to think of it, you know, they did say they might leave if we didn't sort this out, and sure enough, that was round about the time I got ill. But I didn't really think that was the main thing that was going on. So there is an effect, an attenuation on memory that is reflected in the reduced activation in the hippocampus that we saw in the brain scanning results.
And I'm also wondering if there was a finding around the way emotions are regulated between patients and controls.
Well, again, when people have to deal with strong emotions, it's a natural response to try and regulate, to try and deal with the emotion. And we have lots of different strategies. We can try and distract ourselves from it. We can try and put the emotional thing out of our minds. Other people might be very prone to becoming overly aroused or anxious or depressed or whatever it is in response to the emotional stimulus. Others may take the emotional stimulus and deal with it and reprocess it, and I suppose in the most healthy way come to some accommodation. And all of these different strategies have been studied in brain imaging, and we find again that it's this inferior frontal region that is very responsible for emotional regulation, especially when it's of a sort of adaptive, healthy kind. So if emotions bombard us unchecked, the emotional parts of our brain become very active, like the amygdala, and you don't see much activation, as it were, higher up in the brain. However, when people are demonstrating an ability to regulate or process emotion, the inferior frontal cortex is what's doing the hard work. And we did find that the patients were at least trying to perhaps regulate these emotions. So the inferior frontal cortex was indeed quite busy during this experiment.
And was there a difference between patients and controls? You may have commented on that, but I wasn't sure.
there was a slight difference in that the patients activated the inferior frontal cortex less strongly than the controls overall. So perhaps they were less good at regulating emotion.
Right, right. Now, let's go back to the thing that happened with the hippocampus, because at the heart of this conversion disorder, which is in a way what led Freud to postulate things like the unconscious, is that, let us say someone has a paralyzed limb, there's no obvious neurological cause for it, or medical or organic or biological cause, and they seem to benefit from the paralyzed limb. They avoid an exam, let's say, they were meant to go to, or they don't have to turn up to a stressful workplace. The obvious conclusion is that they are malingering. In other words, they're consciously aware of what they're doing, they're pretending to have a paralyzed limb, and there's a clear gain, there's a clear motivation. But hysteria or conversion disorder is about the idea that these people are doing their best to move the paralyzed limb, but they can't. It's somehow beyond conscious control.
Yeah.
Does your study tell us anything about that very important notion of, are these people really consciously aware that they're not moving the limb, or is it beyond conscious awareness? Does that make sense, that way?
Yes, it does, and that obviously is a very key question. I don't think our study is able to really distinguish that. We looked at this notion of the escape events purely because, well, a lot of bad things happen to people, and they don't develop a paralysis. And a lot of bad things happen to the people with conversion disorder, and they didn't have that effect. So we did need to at least have some ideas, why were those particular events the ones that seemed to precede the development of the conversion disorder. But I wouldn't want to say that it was conscious or unconscious, and the whole argument about whether it's malingering or not is very contentious. My view is that it's a bit of a spectrum, that the abnormalities occur perhaps in a state of great emotional arousal, and then the individual's family or friends, and indeed the society as a whole, starts to change, and people become the subject of sympathy and perhaps start to derive some benefits. And so even if there wasn't any intention to gain secondarily from the illness, it sort of happens, and then it becomes a habit that's hard to break. So whether that's entirely conscious or entirely unconscious is very, very difficult to say. And I think the idea that our brain scanners are going to tell us what we're really thinking, whether we're telling the truth or not, is a little bit of science fiction that we haven't quite got to yet, perhaps thankfully.
So one of the things that you talk about in the paper is what comes first. For example, the change in activity in the supplementary motor area. Is that the thing that changes first and then drives the symptomatology? Or is it you get the symptomatology and that drives the brain changes? I mean, you do raise a question about that in the paper,
yes.
I think.
Well, of course, the patients we're studying have got the condition, and as I say, they usually had it for over a year, up to 2 years was the cutoff in our study. So although we're excluding the most chronic patients, sometimes patients have these conditions for many, many years, it's still fairly well established. So we can't really be sure that the changes we're seeing, this increase in activation of motor systems, is not somehow an attempt to compensate for the conversion disorder. We can't really be sure. We'd have to sort of do the study as these events are unfolding to really be sure about that. And the imaging technique has limitations. All we can say are that one region is correlated with another. As it goes up, the other one goes down, or as it goes up, the other one goes up. We can't really say which comes first, the chicken or the egg. So we have to acknowledge the limitations of these techniques.
So I'm going to ask you now a very, very difficult question, if not an impossible question. So feel free to run screaming from the room rather than answer this question. But given there has been a plethora of recent studies, including yours and your colleagues and several others, is it possible to summarize where you think we stand at the moment in the neuroscience understanding of conversion disorder, and how much did Freud get right, given what we know now, and how much did he get wrong? Is it possible to have a stab at that?
Well, I think sort of research we're doing owes a debt to Freud, and I think Freud correctly noticed that certain events, sometimes childhood events, sometimes contemporaneous events, did lead to these physical symptoms. That was a very important observation then, and it still holds true today. And I think our techniques are trying to unravel a possible mechanism for that. That how can emotions really connect with parts of the brain that are supposedly mechanical? Well, they can, and they do influence each other. But I think there's still a long way to go. I think the other work that we talked about before is very fascinating in trying to uncover how actions are initiated. So the basic circuitry that leads an action to be performed in the body, the sort of last parts of that circuit are extremely well worked out, and we know what happens when part of that circuit's damaged, when, for example, you have a nerve injury or a spinal injury or a stroke affecting the motor system. But what these studies are really shedding a light on is how an idea, an intention, forms itself and starts to become a driving force for the initiation of an action. And that takes you to different areas of the brain, the supplementary motor areas, the pre-motor cortex. So that, I think, has been a very valuable contribution to the work. But philosophically, there's still the problem. It's the kind of mind-brain problem, if you like. Where does the idea, the intention start from? How far back can you go, and do you end up in an infinite regress? So,
and how much conscious awareness is there of it?
Yes, well, but if we solve that problem, then we really will have solved all the problems of the mind and the brain. And I think when we reach that point, then there'll be no more need for research or interviews of this kind.
But what about the hydraulic idea that Freud had, the energy, that the energy had to go somewhere, and this very hydraulic notion he had? Surely the current neuroscience research is really casting doubt on that conceptualization he had.
Well, these were metaphors that Freud used, and he had lots of metaphors. He had an archaeological metaphor of digging deeper, and he had a hydraulic metaphor. So the science of the time, I think, influenced the way he expressed things. Nowadays we talk about computer networks and so on, and I'm sure in years' time people will look back on those metaphors as being very crude. But his idea that if you try and suppress a bad memory, it comes back to haunt you, as it were, because there's a certain amount of energy that has to be released. Again, I think in terms of energy, that's not really a modern scientific idea. But as a metaphor, I still think it carries a lot of weight. And if our experiment is correct, it does sort of hold that if you try and take the sting out of a memory, it doesn't necessarily just go away, and it can, in fact, involve other systems of the brain, like motor systems, and come out in a symptom. It is about how we regulate emotions, and whether we can do it in a very adaptive way that doesn't lead us to deny or turn our back on emotions, and yet doesn't produce worse symptoms. So I think there is quite a lot going for that metaphor, but it is just a metaphor.
So finally, I mean, this research, which is unpacking and uncovering what's going on in conversion disorder or hysteria, is it going to help us with treatment? Because can be very disabling conditions and quite chronic conditions. Do you think this research is providing hope for improving treatments and improving the prognosis?
Well, I would hope so, because as you say, there are very few treatments for these patients, and it can be very, very disabling. I must say that in my own practice, I mean, these aren't clinical trials. We're not investigating a new treatment, but simply having a discussion with a patient about how emotions in the brain can affect the body. I think that is actually a very useful topic of conversation, because often the patients come in with, funnily enough, a very strict dualistic idea. They're convinced that there's something wrong with their body, and they're very suspicious about someone, in their minds, dismissing it as psychological. But if you can counter that with what is really a genuine and modern position of neuroscience, that is saying that the mind and the body are inextricably linked, one can talk about how the events, which of course the person knows about and accepts and is upset by, how that might have affected their body, without getting into the question of, are you putting it on, is it real, is it not real? And I can certainly think of some patients who have found that a very useful way of discussing their symptoms and trying to overcome them, because often it's a question of, well, whatever happened back there when you lost the use of your limb or whatever it was, that was then. Now we've got to try and get things going again. And perhaps when one talks about trying to open up some of the more normal neural pathways to get you in charge of your limbs and get your intentions connecting up with your actions and not being driven by those emotional traumas that are occupying your mind, whether that's really what's happening or whether it's just a very acceptable way of engaging a patient, I'm not sure, but I do think that it can be very helpful.
Professor Anthony David, thank you very much indeed. This has been a continuing professional development podcast for the Royal College of Psychiatrists. And if you're listening to this podcast and want to take part in the continuing professional development or CPD element of the podcast, you will need a code word, which you will then use on the Royal College of Psychiatrists website to unlock the questions for the rest of the podcast and the rest of this module. And that password is conversion. So Professor Tony David, thank you very much indeed.
Thank you.